Danielle is with UF Community Health and Family Medicine, and today they're going to be talking with us all about vaccines, testing, and plans for the summer. I know they're going to talk, they said, for about 25 minutes or so and give us a lot of time for questions. So I'll go ahead and just turn things over to Eric and Danielle.
Hi, thanks for having us. So as Rebecca said, I'm a family physician and I work in the Department of Family Medicine at UF. I also have a master's in public health, and I've been doing for the last 8 or 9 months, seeing patients in the hospital with COVID, as well as managing lots of questions and things coming in from my primary care patients in the outpatient setting. And let Eric introduce himself.
Hi, everyone. It's been an amazing, it's coming up, it's not quite a year, but it's been about 10 months since we had our seminar back in March, kind of not simply announcing that COVID was coming, but not only was it here, but things were going to change rapidly. And it was pretty amazing for us that shortly after that seminar, the UCG in-person services ended and the rest of the world ended there around March 18th. But yeah, I have a few skill sets, one of which is that I have a PhD in microbiology and have a good working knowledge around bacteriology as well as virology. I'm a pediatrician. I work inpatient here at Shands on the pediatric side. And then Danielle and I have both worked for many years around the challenges of infectious disease outbreaks. We've done that more internationally, and it's been an interesting experience to do what we've done abroad here in the States. So we have many of the bases covered in terms of speaking to COVID-19, but we also want to emphasize that no person is an expert on COVID-19 because it is a new disease. So there will be many questions that you may have today that we just are simply not going to know. I should also say that I'm not an epidemiologist, and Danielle is not an epidemiologist either. So some of those more nuanced questions we can't field. Our agenda for the next 40 minutes is ambitious. We're going to spend 20 minutes very focused on some key points that we want to get across to everyone today. And we really want to empower the 46 people on this call to take the messages that we're conveying today to other members of the church community, but also to other church communities as well as the community at large, because a lot of what we're going to talk today is personal, and they're complicated stories that bring up a lot of questions, anxiety, concerns that can expand in kind of an uncontrolled fashion unless you can kind of take a deep breath and take it in steps. And that process is often best done in a person-to-person interaction over a fence or, on the front lawn, with 6 feet apart. But I think to succeed in this next phase, that kind of person-to-person level of communication is going to be key, but it's also going to be successful if it's carried with facts and kind of best practices rather than just kind of skimming social media for whatever is trending at that point in time. I also want to give a shout out. I was trying to cruise the list of participants. Hopefully my mother's on. There's a battle because George Soros is giving a talk at the same point in time, and she was in a debate on which Zoom call she was going to attend. So anyways, it's a pleasure. So our agenda today is to go through basically 8-ish topic areas. The first is just to give a status update on things at the local level, answer some basic questions around testing access and indications to get tested, some emerging topics around vaccination availability, vaccination safety and efficacy, how we should think about this topic of variance, which will become an increasingly common discussion point in the coming weeks. And then I think we're all getting really tired of being cooped up in our houses. And how do we plan for travel, seeing our family with and without vaccination, and especially when different parts of the family are vaccinated? And then also, if we have time, to prime you with some expectations, if yourself or a family member or someone you know is getting hospitalized for COVID or is going to the emergency with COVID, what are the expectations that person should have and their family should have as they go through that experience? So with that, we will start with topic number one, being status. And that has kind of three different categories. We can think about it in terms of the school, in our case, Shands Medical Center, and the community. From the school perspective, I sit on the Scientific, Medical, and Advisory Committee called the SMAC, which advises the school board. And as you know, school started on Monday. Tuesday. And the protocol that was run during the fall to do our best to keep schools open was largely successful. In the background, we monitor the number of index cases that come in. And in the fall, we had approximately 257 index cases. Kids that were contacts of those index cases get quarantined. And then if the protocol is being followed, on day 9, those kids get tested. And if they're negative, they come back to school on day 10. If they're positive, they stay home and finish out their quarantine for at least 14 days. And out of those 257 index cases, about 5% of the contacts at day 9 were positive, meaning that 95% were negative, and they're able to go back to school. When we do contact tracing for those kids, we did not see a single incident of secondary transmission from those primary index cases, meaning that in the classroom environment, that protocol was very successful on keeping the students and their teachers safe. Now, there's a large caveat there, which this is in the classroom. And what we've found is that activities such as sports and really the activities around the sport event have contributed to infections and secondary transmissions. And that's more so at the high school level. So going forward this spring, we're going to keep the same protocol, but we acknowledge that the level of disease in the community is much higher. And some of these sports have shifted from outside sports to inside sports like basketball and volleyball and wrestling. So that's the challenge that we're facing right now. And we expect probably significant bumps in cases in the next week or two. Danielle can speak to Shands.
Yeah, so we're seeing over the last week or two about 150 patients who are hospitalized at Shands. Might be slightly higher. The numbers that they're reporting to us don't include the ones that are being investigated for COVID and things like that. We are basically seeing a large influx of people into the emergency room, and I don't have numbers for that. And the good news with that is that compared to April and even July, the people who come in are less likely to be admitted because we have a lot of, we kind of have a higher threshold. We've learned a lot over the past 9 months. And we also have the option of doing some treatments, which we'll talk about later, like infusion of monoclonal antibodies in the emergency room before, and then patients are able to be sent home. So we'll talk more about that soon. But in general, the inpatient side is increasing. And although, you know, our hospital leadership tells us often that we're not in sight of running out of ventilators, we are feeling the strain as hospital workers on the inpatient and emergency room side. And there's talk of, you know, adding more inpatient teams and pulling residents to cover more patients and things like that.
Can I just interrupt quickly and ask if could you just talk a little bit louder? I've had just a couple
okay.
chats about, or I don't know if there's a volume setting on your mic.
Sure.
Thanks.
We can bring it closer.
Okay. Thank you. Sorry.
Anything more on Shan's?
No.
When you see in the newspapers, there's different ways in which they describe a hospital's capacity. There's bed capacity, but obviously those beds have to be staffed. And when Danielle's talking about staff getting stretched, she's thinking of nursing capacity, respiratory therapy capacity, and physician capacity. Those are the stretches. And so as the institution gets stretched, there's certain thresholds that the institution makes changes. One of those thresholds was 100 inpatients of COVID. That happened in the last couple of weeks. And so Shands did a reconfiguration to adjust to that. We're around 160 inpatients now, and it's anticipated that we'll kind of go over the 200 level maybe in the next couple of weeks. So as those thresholds are hit, maneuvers are taken to adjust for that. Someone asked me the other day what crisis care means. And in a public health and a global health mindset, what that means is a crisis happens medically when you start to compromise your medical decision-making based on resource allocation, which is happening in Los Angeles. But we're not near that point at all right now at Shands, so that's positive. At the community level, I do appreciate the Gainesville Sun's publication of numbers each day. And I would say that in any article or publication with numbers, it's never going to be perfect. And what you hope for is that the inconsistencies are consistent over time so that whatever noise or error is in there, it's accommodated for. And so the trends are reliable. And so you have seen in the newspaper that, gosh, that was back in August, we were around like 30 cases a day, and then it was 40, and then it was 50, and now we're, kind of 200 plus a day. So the curve is going upwards. And I don't want to dwell too much on those numbers because whatever I say is going to change tomorrow. But I will say that the curve is going upwards. And the effects of COVID that we've been seeing the last week and a half have been manifest probably from what I would call three generations of COVID transmission post-Thanksgiving. The Christmas effects will be coming on shortly. And then the effects from students coming back and starting classes on Monday will be that next set of effects. So that curve at the county level, I do not see changing at all for the next several weeks unless a massive public health intervention is imposed, but I don't see that happening. That would be, in my mind, a statewide shutdown.
So we wanted to make sure that everyone is aware how to get tested for COVID-19 if you do have symptoms or you have any other reason to be tested. For UF patients, anybody who has a primary care doctor in the UF health system, you should contact your primary care doctor, and we have several different mechanisms of getting you tested. There is one big change if anybody's been tested through UF Health before, which is that we've changed from a Spring Hill on 39th Avenue doing a drive-through testing. And now starting tomorrow, we're going to be doing it at the Nationwide building down on 34th and Williston Road. And so for anybody who's gotten tested through UF Health before, I'm sure they'll tell you when they schedule you, but that's going to be drive-through testing at a different location. The main reason is we're using the Spring Hill site now for vaccinations. So for any UF employees, there's really broadening testing available through the Screen, Test, and Protect. Everyone should be getting emails about that, but feel free to ask us if you have any questions, and that's happening on the UF campus. And then for basically anybody else, we're still available testing through the Department of Health, and they've really expanded their hours. They do 8 a.m. to midnight, basically, And the phone number is the same, which Eric put in the chat, but it's 352-334-8810. And I think, sorry, Eric was typing as I was talking. That phone number is for testing. It's not for vaccination.
It's for both.
Okay.
Yeah. Yeah, so you can call that number to schedule a vaccination appointment if you're over 65. I do not know all the caveats that are coming up with that, and I haven't called it myself, but it's for both testing and vaccination appointments.
So that brings us to vaccine availability. At this point, beyond College of Medicine employees and people who care for patients with COVID or potentially exposed to the public who might have COVID, we're really focusing on over 65s, but at this point, the vaccine is available for anybody who's interested as a Alachua County resident who's over 65, whether you're a patient of UF Health or not, through the health department. And if you're a patient of UF Health, you can get it through our drive-through vaccination at the Spring Hill site. For UF patients, if you're getting it that way, we did do it in a way that sends a message through your MyChart, which is an app on the phone or an account on the computer. I know that pretty much everyone on this call, if you're able to do Zoom, is more tech savvy. So if you have friends or family members who are over 65 who don't have a MyChart account but are UF Health patients, they should contact their primary care doctor about a vaccine if they're interested. That brings us to, I see a lot of questions about other things, so we'll loop back to them after we cover all our main points. But so in terms, that brings us next to vaccine safety and efficacy. I'm gonna let you start with that.
Okay, so basically, I want people to organize their thoughts in terms of knowledge, questions, ideas that are actionable and those that are not actionable. So there's a lot we could cover today, but we're kind of focusing on the things that are actionable. So while Johnson & Johnson and AstraZeneca are bringing vaccines online, today's discussion is really around the Moderna and Pfizer vaccinations, because those are the ones being deployed.
And just for clarification, the Pfizer is mostly being used for UF Health employees because of the cold chain concerns. It's really difficult to kind of spread in the community. The Moderna vaccine is what most people who are not UF Health or Shands employees are going to get.
Biologically, both vaccines are basically identical. I can't speak towards the amount of vaccine that's being injected into your arm. But biologically, they're the same thing, and they're looking for this thing called the spike protein that is the antigen that conveys the immunogenicity. And so the regimens are 2-dose regimens for both vaccines, and the trials will run with endpoints or looking at did you or did you not get symptoms, and the endpoint was after that second dose. And so the efficacy rates of 90 or 95 plus have been published for both vaccines are based on after that second dose. So the efficacies, as I mentioned, are around 95%, which is mind-blowing for me, who's worked in vaccinology in the past, because we're happy if we get 60 or 70% efficacy. Getting 95% is outstanding. So from an efficacy perspective, it's almost a moot discussion around efficacy. And really, the questions then pivot to side effects from vaccination, as well as logistics of we're in a crisis nationwide. What happens if we blow all of our vaccine right now on single dose regimens, hoping that in time we can get more vaccine to give second doses? And that's been in the press just recently. And the benefit of that is you get twice as many people vaccinated. The downside is the efficacy might be less. When I say less, I mean roughly half after one dose, in the kind of 50% range, and then after the second dose, roughly 95%. Those numbers are highly variable after the first dose, because a number of people in those clinical studies that got sick between the first and the second dose is really low. And so the confidence in those numbers is
pretty broad.
Is pretty broad.
Yeah, to give you a sense, the Pfizer study, was almost 40 to 50,000 people included, and they the people who got sick in the whole study after the 2 doses of vaccine was in the hundreds, but we're talking about less, around 1 to 200 people who got sick in both placebo and trial arms for the in between the 2 doses time. So it's really hard to tell. They haven't done the studies. There's a lot of chatter on the news and so forth about, well, what if we just did 1 shot and then we'd get a lot more people, but they really didn't study it that way. And so most public health experts are not recommending that at this point. That might change as we get more data.
Yeah.
And then in terms of the Moderna, they had even fewer. They had like 80 people who got sick in between the 2 shots. So really, the numbers are too small to make good understandings about what protection it incurs after 1 shot only.
So the take-home point from that discussion is, in an ideal world, everyone would get the 2-dose regimen. But in a crisis, as well as with challenging logistics, there might be some states that pivot towards a 1-dose regimen. I can't speak towards what Florida is going to do, but that is the discussion that's being had. So that takes us to side effects. I just got vaccinated. I just had my 2nd dose.
We both did.
And Danielle and I had different experiences, which I think is going to be the typical, storyline that comes out of this. After the first dose, which was December 16th for me, and shortly thereafter for Danielle, we both had sore arms and kind of a little bit of fatigue and a little bit of kind of this dull headache that went away and was sort of a non-issue. After the 2nd dose, do you want to describe your symptoms?
Well, I mean, I generally felt achy and took ibuprofen for a day, but I think really, and Eric's going to describe his as well, but really what we want to emphasize is that this is the expected course, because it's your immune system responding appropriately to the vaccine. So go ahead.
Yeah, so Danielle had mild symptoms in the first go around, mild symptoms in the second go around, and my symptoms were like pretty classically mild to moderate flu-like symptoms for 36 hours. That included a sore arm, kind of body-wide muscle aches, a headache that I would describe as almost like a hangover, and just a malaise. And as I was going through those 36 hours, I was thinking to myself, boy, yeah, this is an inconvenience, but it's a lot better than being dead.
Or being hospitalized.
Or being hospitalized in all those various situations. So if there's a message here, it's twofold. One, when you get vaccinated, schedule it such that you can take the following day off of whatever you normally would be doing. I wouldn't plan on working the following day. So if there's a way to schedule things so that you can be vaccinated and then take the next day off, great. If you have symptoms like mine, you'll be home, watching Netflix. If you have symptoms like Danielle's, you might well be able to go to work and have a normal day. But I think for a transparency point of view, those 2 stories are important to convey forward, and you weigh them against all of the much more serious issues of if you got the disease. I don't have anything more to add on vaccines.
No, well, I'm sure there'll be plenty of questions, so we'll loop back to it, but so we'll move on to the variants.
Yeah, so my old background was in evolutionary biology. And if you want to take a short course in Darwinian evolution, it is happening right now with COVID-19. So anytime that an infectious agent is expanding in just crazy billions and trillions of numbers, and there are selective forces being vaccination or medications, or even the host immune system. Those are selective pressures that cause the agent to change a little bit. And sometimes those little changes have zero consequences. Sometimes they have significant consequences. So of the three things that we worry about with these variants that are coming up, and we expected them and we've been monitoring them, there's three things that we worry about. The first thing is transmissibility. The second thing is severity. And then what I'm interested in is with COVID, shifting disease down into younger populations. Because that's just, if there's one bright side, it's that the kids have been able to escape the story for the most part. So what we know right now is that the variants coming out of South Africa, the UK, these variants have been discovered across the US and multiple places, are more transmissible. And we can't speak to severity, and we cannot speak to younger populations at this point in time.
We don't know how that might affect the vaccine either.
Yeah, so thank you. That was the fourth thing, was as these variants pop up, they happen in different parts of the genome of the virus. And we do see some mutations happening in the part that affects what the vaccine's looking for. But there's a redundancy in the way that the vaccine was built. So you can have a small tweak in a variant, but it's not going to affect the vaccine efficacy. When it is documented that the vaccine is being challenged by a variant, it won't be shocking, and there are plans for that. So like the flu vaccine, we get a flu vaccine every year because the flu does change over time. Hopefully we don't get a situation where we'd have to have COVID vaccines every year, but that is a possibility. So I would not view the variant discussion as actionable. You can take what we just told you, put it in a Tupperware, and put it in the I'm not going to worry about it now bin. Okay, so let's talk about
We gotta hurry.
expectations as you go, not you, but let's say someone in your family is diagnosed with COVID, and what their journey might look like briefly.
Yeah, so depending on the patient, everybody has different symptoms, and for some people they can be very mild through the whole course, and other people they can be stronger right away. But there's a third group that kind of has mild initial symptoms, but then over the course of a week or 10 days can get progressively sicker. So first of all, I would say that paying attention to your body and not kind of minimizing symptoms is very important. It's always a good idea if you have a primary healthcare provider to get in touch with them at the start of symptoms and kind of monitor things as the course goes along. The one thing I've been seeing a lot of is people who are exposed to patients with COVID, and they say that they're asymptomatic, and then we get them on the phone and actually, oh yeah, they have a headache, or they're feeling fatigued, or they're having a little cough. So don't minimize those symptoms. Those can be very mild symptoms of early COVID-19. So what to expect if you have more severe disease. So if you're noticing that you're having trouble getting out full sentences without taking a deep breath, or you're not able to do, kind of walking around the house or walking to your mailbox like you might have done before, that's a reason that you really need to be evaluated, probably in the emergency room, to make sure that you're not having low oxygen levels. And what we're doing is, like I said before, we are providing at UF Health anyway, if you don't meet criteria to be admitted to the hospital, you may still meet criteria for getting a monoclonal antibody treatment in the infusion center, and then go home. So that, I think for some people, if they're kind of in that moderate zone, they're not sure if they need to go to the hospital, that is something that's an option that people might be able to get. That can also technically be coordinated from the outpatient, although I'm not sure that we're doing it very often because most of the time, we don't have that information. Are you having low oxygen levels or not until you come in? And
the monoclonal is a highly restricted intervention that does come with some drawbacks for people with a history of anaphylaxis. So it is a very specific criteria that you fall into in the ED that they send you to the infusion center for.
Right. And then if you do need to be admitted, it's people who are needing oxygen and who don't normally have oxygen at home are for the most part getting admitted to the hospital. And I think that's where a lot of the fear and kind of the unknown happens. So that's why we wanted to talk about it. So for the most part on our COVID floors, we are not allowing visitors. And so just to be aware that if your family member or loved one is admitted to a COVID floor with COVID pneumonia, you may not be able to visit. And I know that's really hard for people. The nursing staff and the doctors should be touching base with you on a regular basis as long as the patient is given permission and your name is on the sheet, but sometimes it does take some proactiveness to kind of call and get regular updates. We are, for the most part, many of our patients are getting remdesivir and dexamethasone treatments when they're admitted, whether it's to the floor or the ICU or the intermediate care unit. And I would say that another positive, like we said, we've gotten better. We've learned from other places. We do have a little bit more experience in terms of caring for people with COVID-19. So our outcomes are doing pretty well, but it can be a really long course if you're admitted. So I think that's the other thing. A lot of people maybe minimize the effect of getting admitted to the hospital. It can really wear you out. A lot of my patients have ended up in rehab centers afterwards or really needing a very long, months of recovering till they get back to their normal activity. So, and it's still very unpredictable of who's going to have severe disease and who's going to have more mild disease. So
visitor policies.
Visitor policies in general in Shands for adults are 1 visitor. But like I said, for COVID wards, we aren't having visitors. So I don't know North Florida and other local hospitals what their policies are.
And if you are 25 years and less, there's a good chance you'll actually find yourself on the pediatric service, which is a new feature. In the pediatrics, we're taking basically anyone under 25 that has a non-COVID issue. And in pediatrics, we have a 1-parent policy in the ED and on the wards. So there's one last thing, which I think we can hit in 1 minute, which is just planning. And in brief, we canceled our family reunion last year, and we're going to do so again this summer, cancel it, because we feel like until at least all adults are vaccinated, having a large family gathering just doesn't work, at least for our family. Now, my parents hopefully will be vaccinated very soon. They're in their 70s. Danielle and I are vaccinated, which would mean that all the adults are vaccinated. So they're welcome to visit as soon as they finish their vaccine regimen. The caveat there is that our daughter is 9 years old and will not be vaccinated. So she may or may not be waltzing into the house with COVID, but we have the confidence with the vaccine that if we stay vigilant with our daughter, doing social distancing, masking, hand washing, and we're screening her for symptoms, that is a risk that I think we're willing to take as a household. Now,
so I think that's the big point, is that masks, the distancing, and the hand washing is not going away anytime soon, even as we see more and more people getting vaccinated. So,
and we have had some documented cases even here locally of people in this kind of peri-vaccination phase getting COVID, being asymptomatic, but testing positive. And the vaccine endpoints were only for symptoms, which doesn't speak to the, with vaccination, is it possible that you still get the virus in you and then also transmit it? That is possible even in a vaccinated state. I'm sure there'll be some data that will inform us on that soon, but we don't have those. It is 11:51. We can field questions. I'm not sure who has what at noon, but if we need to roll over for 10 minutes, we can do that for sure.
Thank you. So we're going to start with Mary Ann. Are you there? You can unmute yourself.
Yes, I'm here. Thank you both so much for doing this. My question has to do with what you just were talking about, and that is that the vaccine, which I'm 100% looking forward to getting, has very high level of efficacy for symptomatic disease. If we know that a lot of transmission is through people who are asymptomatic, I don't understand how this gets us out of the pandemic. Couldn't it keep circulating among asymptomatic people?
So the first part to your question is just giving the epidemiologists a few more months to test that question of rates of infection among vaccinated people and then rates of transmission among vaccinated people.
yeah, I think we can't answer it right now, but we might be able to. It might be true that in the future we find out that they can't transmit it either, but we don't know that right now, and that's why we're being cautious.
And so I would sort of hold your question and concern until those data come in, and until that time, keep your mask on.
Yeah, but ultimately, I think the question comes from an area of concern, like how do we ever get out of this? If we're protecting people from ending up in the hospital or dying, then whether it transmits or not is back to kind of, I think we're all out of the habit of having common colds, but for a long time we were able to have common colds and that was okay. So if it came back to that, if the vaccination just got us down to a level of mild or asymptomatic disease, then it might be okay.
And you can rely on history. I mean, one example is thinking about the polio. The polio vaccine alone didn't stop polio. It helped, but also chlorinating pools and doing, a bunch of public health maneuvers that just now seem like standard of care, common practice. A lot of those were inspired by the polio outbreaks. And we have the pleasure of going about our day not worrying about polio virus. So we can emerge out of these pandemics successfully.
Next.
Sure, I'm gonna jump in line. I'm gonna go to Sandra next, but before that, Sandra, just wait. I wanted to jump to Sally's question because I want to make sure this gets answered with the most amount of people on. But what do you say to those that are hesitant or reluctant to get the vaccine?
Yeah, so for me, I really like to talk to people directly about what their hesitancies or their reluctances are. For some people, it's a fear of something that was, with this quote, Operation Warp Speed, there's some rumors out there that it was not adequately tested, and that I can definitively say that is not true. They definitely sped it up the process by doing some trials simultaneously. But in terms of the actual amount of data that we have on these two vaccines, I feel very confident that they went through the normal safety process that any other vaccine would. And then the other thing about how fast it was is really this new technique of taking this mRNA material is a lot faster than other types of vaccine development techniques. So so that's one common concern. For other people, what are other common vaccine hesitancy?
Well, I was just going to go off what Danielle said. I think transparency is critical. So Danielle had mild symptoms. I had flu-like symptoms for 36 hours. I think if you set up expectations such that people don't experience like a bait and switch, that storytelling will go better. And sort of, that's going back to the beginning of the talk about kind of the neighbor to neighbor conversation of, oh, I'm not sure what I trust in the larger world, but I do trust my neighbor. And so if they share their experience and it was reasonable, then you have that kind of local transference of trust. And I think the hesitancy goes down.
Yeah, the other common misconception is that because this is an mRNA vaccine, that this is somehow affecting our genetic material. And there's even an internist on the internet who's forgotten her basic biology. These mRNA particles that go into your cells never enter the nucleus of your cell, but they do kind of produce the protein so that your cells can show the protein to your immune system, and then your immune system can recognize it in the future.
And mRNA degrade.
Yeah,
they're sort of like the blueprints that you print off of a database. The database will exist, being the DNA, but the blueprint's going to get used, and then it's going to go in the shredder.
Yeah.
Okay. Sandra, you're next. Are you there?
Yes, I'm here, and thank you so much. Can you hear me?
Yes.
Yes.
Okay, so I'm really asking for my daughter Caroline, who actually grew up in UCG, and I appreciate very much your time and focus here, Eric and Danielle. This has been really informative. She is late in her pregnancy. She's planning to breastfeed, and she has the opportunity for either the Moderna or the Pfizer and vaccine, and she currently is moderate to low exposure. And we're just all concerned because I guess there's not much research or information about pregnant women. Do you have any insights?
Yeah, so as with many things in medicine, unfortunately, pregnant women, fortunately from a safety perspective, but we're very hesitant to do trials in pregnant women. And it's the bar and difficulty of doing them is very high. So it is true that we haven't studied these vaccines very thoroughly in people who are pregnant, but we've also seen a good amount. Personally, I have two people who are in the end of their pregnancies who are healthcare workers who did get it. And really the reaction is the same. So far, we have no kind of theoretical concern, and the OBGYN department and ACOG, which is the American College of OBGYNs, have said that if people are recommended to get it based on their risk factors, that there should be no reason to avoid using it during pregnancy. So that's all I can say. I think it is an individual decision because it hasn't been studied, but I have no theoretical reason to believe that it would cause harm.
And Sonia Rasmussen at UF published a paper on this topic in the New England Journal about 3 weeks ago. I think that's a really important article to look at. And then the other thing is, back in midsummer, they had enumerated the risk of mortality for pregnant women, and it was I might get this a little bit off, but it was around a 0.5% in that kind of late 30s pregnant age group. And if you were went from not pregnant to pregnant, then your percentage went up to around 6%, which obviously the numbers have changed a little bit over time, but that's a pretty high jump. So
yeah,
that is not a risk that I would want to take, and so I would get vaccinated.
Yeah, that is absolutely a fact that pregnant women have higher risk of severe COVID disease. So.
All right, Dominic asked
Thank you so much.
Thanks, Sandra. Dominic asked, how would you think about outdoor sports still being low risk despite increasing cases?
I can speak to sports pretty well because of our work in the SMAC committee in the fall. I think outdoor sports, with the screening and maneuvers to keep the athletes safe as they can be actually worked out. What the problem was the dinner beforehand, the party afterwards, and the crowd.
The bus ride.
The car rides. So it's actually not like the play on the field. It's all the things around it. So initially, I was of the opinion of no sports. But then as the data came in, I was like, okay, well, it depends. So my answer would be, it depends on if those off the field activities can be addressed. If not, then don't do it.
Yeah, it also depends. I mean, for a child or a family member who would be playing, I think you have to take into account your own family's risk as well. So if that child, playing a sport could potentially get COVID and bring it into your family, how bad would it be for your family? So.
And it's relative. Like Lucia was out on the tire swing with our neighbor, and we feel like play is really important to mental health and physical health. So it's kind of weird to say, okay, no on the field sports, yet I'm allowing my daughter to play on a tire swing right now. So it's contextual.
Okay. We're gonna, I think we usually wrap up around 12, but we're gonna keep going with questions. So we'll keep you guys maybe 15 more minutes or so, if that's
no need to wrap up, Rebecca. Keep it going.
Okay. So Tracy asked, can you explain rapid testing, PCR testing? What would you recommend if you need a test?
Well, so for the science nerds, I'm going to go off on a tangent briefly, which I think it will be important in about 2 months. The PCR testing, I would say, is the gold standard. It's the most sensitive and robust. And in some ways, we get into trouble because it's so sensitive, because patients continue to shed virus out of their, nucleic acid out of their nose as well as out of their stool, long past the time that they're symptomatic, as well as shedding infectious particles. And with these new variants, as the variants change, some of these PCR tests are looking for multiple targets. And they've already picked up that one of those targets in the PCR test intermittently is not working.
With the UK variant.
With the UK variant. And so they can actually use parts of the failure of the PCR reaction to detect variants, which I think is a fascinating nerd thing. But in general, PCR is better than the rapid test that's looking for the viral antigen. And it's sort of one of these situations that if you can't get access to the PCR test and you really need to be tested, then the rapid antigen test is a good substitute. And I would really favor it more as like a screening maneuver rather than a definitive diagnostic. Its specificity is very high, the rapid test. The sensitivity is lower. So if you do get a positive, it's probably a true positive. If you get a negative, you have to scratch your head a little bit.
Yeah, so that's why, like Eric said, if you have, flu-like symptoms and you get a negative rapid test, I probably would not let you go hang out with grandma. But if you're using it as kind of, I was exposed, or I'm getting, or I feel fine, I think that's a reasonable test to use. Or if you're using it just to know, but you're not actually gonna go around anybody anyway, it would, if it's the only option. I do prefer PCR as well.
And the PCR test also, like any diagnostic, depends on when and where you test. And so the phase of your illness will affect the performance of the diagnostic. And there are some times, and it's unclear why, that a patient can have florid COVID illness and test negative by PCR. And that can be quite frustrating and daunting for both the family and the clinical team.
Okay. Steffi asks, and I'm an English major, so I'm not sure if you answered this when you talked about the new mutations, but do you know anything about the spike protein being conserved enough to be covered by the vaccine, even for the new mutants?
Yeah, so
Mutations?
we basically covered it, but I would just reiterate that we don't know yet.
Yeah, we did look up last night that both Moderna and Pfizer cover the full sequence for the spike protein. And within that sequence are called multiple epitopes, multiple antigens. So if one little piece changes, you have all the other pieces that can provide redundancy. So that's why we're less alarmed.
Okay. So I know you talked a little bit about the UF Health My Charts. If you don't have a UF primary care physician, can you still get vaccinated through theirs?
I would say if you do not have a UF Health primary care physician, you probably should go through the health department, although I'm not positive about that. If you have UF Health specialists and you have a My Chart and you got a message, then by all means, schedule yourself and get a vaccine. I just realized as you're asking that question that I don't know 100% for sure that you have to have a primary care in UF Health, but if you do have to be a UF Health patient with the active My Chart.
There's one other thing around vaccine hesitancy that's really, really important, and I forgot to mention it, which is the topic of association versus causation. And this is something we deal with in pediatrics all the time. Because in young children, they're getting vaccinated, every couple months, and they're getting a whole bunch of vaccines at those time points. So the chances of a child having some sort of illness or a seizure or some sort of event in their life, within 10 or 14 days of getting vaccinated, the odds of that are pretty high. And those are associative events, but not causative. And so as I think more and more people get vaccinated, we have to be very, very mindful around association and causation. I think that's going to be the challenge for messaging as we go forward.
And I do see someone saying that you don't have to have a UF PCP. So thank you for that information.
All right. Sheila asks, could you define more transmissible?
70%, 50 to 70% more transmissible. So there's something called a reproductive number, in which for every single case, how many cases are generated from that. So it's called the reproductive number, or R naught. If it's 1, it means one case leads to 1. If it's 2, one case leads to 2. That transmissibility is going up by 50 to 70%. So I actually don't know. I'd have to look into this. If that means that, like, if the R naught is 1.5 right now, is the new variant R naught 2? I don't know that epidemiologically.
But yeah, it basically means you could potentially infect more people.
Okay. John and Fonda Eiler ask, when do we think UCG will be able to resume more or less normal activities on our campus? I'll
defer that to the COVID committee and the
Yes.
and the administration of the church.
Yeah, so I would say right now, and Danielle and Eric do advise us on our COVID advisory team, which is greatly appreciated. Right now, with where we are in the red, we don't feel we're not moving towards anything right now out of an abundance of caution. We have been very pleased with how our sort of drive-through events have been, how some of the smaller like musician recordings and things have gone, but we are trying to be as safe as possible, especially at this stage in the game. So just a little teaser, we are trying to possibly think of something in person for Ash Wednesday coming up in February, but yeah, just please keep monitoring the events emails. We put a COVID update in there every week, so stay tuned.
I think that question, we're kind of listing out the positives to kind of wrap up the session with. And the vaccine is a tremendous positive. It is going to greatly and positively impact that question. And I think you will be surprised at how quickly over 65s get vaccinated. A twisted benefit of vaccine hesitancy is there might be a little bit more vaccine for those that are wanting to get vaccinated. So I think that the answer to that question is going to change in a very positive direction in the coming weeks and months.
Jackie Davis asked if we could repeat the best way to access shots. So we can put that number for the Alachua County Health Department. I'll put that down in the chat again so it pops up. But I guess your advice is if you're through UF right now to contact them, and then if you're not, to contact the...
Yeah, and again, this is all just healthcare workers and people over 65. So if you're under 65, hold your horses. I'm hoping it's coming soon.
So Julie asked about what do you think of Gainesville Health and Fitness? I guess maybe gyms in general. I don't know.
Probably don't want to speak to it, any one entity.
Yeah.
I think of it more as groups of people with plus minus adherence to masking in a closed space, and the liters of volume that are of air volume that are exchanged between those human beings.
Okay. I have a question here from Katie. At what point should a person get tested? Day 1, 3, or 5 of not feeling well?
That's a good question. I mean, I think if you're not feeling well, I would say get tested as soon as possible, because the tests aren't, unless you do get a rapid test, most tests are turning around in 24 to 48 hours. So in order to have the soonest amount of information to be able to contact anybody that you might have come into contact with and give them a heads up, the sooner the better. But do you have any different opinion or?
No, I agree. I get a text message pretty much daily of someone whose family member either was exposed or was tested positive. And that, and they ask me, well, should I be tested right now? And I go back to Danielle, if you're symptomatic, yeah. But if you have an exposure on day 0, the virus has to infect, reproduce, get to a sufficient number to get that PCR to test positive, and that's going to be day 3.
Yeah, I think that's the most important. Is the most confusion comes if you've been exposed. So if someone calls you and says, hey, I tested positive, we just had dinner last night, or whatever, then you getting tested today is not a get out of jail free card. So if you're 10 days, 9 days out from the exposure and you get a negative test, you're probably fine. That's the school board's plan. But if you get tested before that, you could have a negative test today and get sick tomorrow.
Okay. Well, we are at 12:15 and I don't have any other questions in the chat. I don't think I missed anyone. If you do have a question, or Fletcher, do you have a question?
Well, listen, on behalf of the UCG Sunday Seminar Committee, we want to really thank you. We're giving you a great big round of Zoom applause here. Thank you so much for all your help.
Well, it's our pleasure.
Have a great day, everyone.
Thanks.